The right ventricular hypertrophy has a probably better correlation with ECG, and there's a classification system by Chow and Hem, which is quite useful, and they divided into the type A's right ventricular hypertrophy, type B right ventricular hypertrophy, and type C right ventricular hypertrophy. Well, in type A, this is a kind where you would see in situations of pulmonary stenosis and in conditions of severe congenital left to right shunts. And the pressures in the right heart are extremely high, and the pulmonary artery systolic pressures would be around 85 mmHg or more. And axis wise, there would be an extreme right axis, and when you look at the lead V1, that will show a simple R wave, which more like looks like letter A. Type Bs would be seen in situations such as in mitral stenosis, and there would be a moderate elevation in the pulmonary artery and right heart pressures, and the axis would be towards the right on the frontal plane leads, and the V1 would show an R followed by an S, and R would at least be equal to S. There's another variety, the type C, and here there is a axis illusion or pseudo left axis. What happens is that the axis shifts so much towards the right that it's almost left, and this phenomenon is called as axis illusion or pseudo left axis, lying in the minus 90 and minus 180. And this kind of condition is seen in folks with COPD with predominant emphysema-like situation, the pink puffers. And here there is hyperdistension of the alveoli and the terminal bronchioles. And there is a dominant S wave in 1, 2, and 3 leads. So in type A's, there would be a R wave and no S wave when looking at lead 1. And in type B, there would be a deep S that follows the R, tall R wave when we look at the lead V1. What's happening in type B's, which is a moderate form of right ventricular hypertrophy, what's seen here is that the S wave, which basically represents the left ventricular forces. So what's happening is that the left ventricular forces are trying to now balance and trying to basically finally pull the forces of depolarization back into the left side, and therefore a S wave is seen which is trying to basically overbalance the anterior right ventricular forces. Talking about the AV blocks. Now, when we talk about AV block, it's important to understand where exactly the block is, to look into whether the involvement is at the level of the AV node His bundle complex, or is it involving the bundle branch system. For AV conduction to fail, and for this failure to be due to the bundle branch system, it's important to realize the fact that both the branches of the bundle branch system have to not function for this AV conduction failure to happen. The AV nodal cells, in a situation when they're diseased or intoxicated, would show a fatigue that increases and ultimately ends in a failure of conduction, but then there is a subsequent recovery. And the AV nodal cells are activated by slow inward currents. The bundle branch cells show an abrupt failure. So it's like when they fail, it's abrupt. And for activation, they would need a fast inward sodium current. But the AV nodal cells would show a progressive fatigue and recovery. So it's not a like a situation where there is an abrupt failure. And it's important to realize that by looking at the QRS, if it's a narrow QRS, the bundle branches are functioning normally, and the failure of conduction would be located in the AV node. In adults, if the PR interval is greater than 0.20 seconds, then it's considered prolonged. Now, if the PR interval is fixed and the impulses from the atrium are taking longer time to reach the ventricles, and the PR interval is fixed and it's greater than 0.20 seconds, it's a first degree block. Now, in a first degree AV block, the problem could be at the AV node or a single bundle branch. And if the problem is at the single bundle branch, then basically the conduction has to depend on the AV node and the single functioning bundle branch. The first degree AV block are not life-threatening conditions and they do not require intervention. Often there are PVs, those are hidden in the preceding T wave, and this happens in situations where the PR interval is pretty prolonged and a T wave will show the bump. And this hidden sinus P wave can actually be unmasked by creating a temporary AV nodal block by slowing the sinus with the help of a carotid sinus stimulation, and therefore proving the point that the rhythm is actually a sinus rhythm with first degree AV nodal block. The second degree blocks, basically what happens is that few impulses from the atrium eventually reach the ventricles, whereas the others are blocked. Now, there is a type 1 or Wenke block, second degree block. Then there is a fixed ratio type of second degree block. And then there is a type 2 or Mobitz 2 type of second degree block. The type 1 Wenke block, location wise, it's always located in the AV node. And the fixed ratio type of second degree block may be localized at the AV node, or it could be in the bundle branch system. The Mobitz 2 block is always at the bundle branch system. The type 1 or the Wenke block will have certain important features, and it's important to have a look at two or more PR intervals, and then one would notice a progressive prolongation of the PR interval. And at a point where the PR prolongation is maximum, then there would be a blocked P after that maximum PR prolongation. And after the blocked P wave, there would be a subsequent recovery with a short PR interval. And as mentioned before, that there is a progressive prolongation of the PR interval, it's just important to realize that even though the total PR is longer, but the amount of prolongation of PR is less with each beat. And because the increase of PR is less with each beat, there would be a shortening of the RR interval. Therefore, there would be a prolongation of the PR interval. This would be accompanied by a RR interval shortening. This is what is seen in a typical Wenke-Bach block. It's called as the Wenke-Bach paradox. And what's happening is basically the RR interval shortens, and then there is a increase in the PR interval, and the increments are decreasing. in the PR interval, although the net PR interval is increasing. And then there is a atypical Wenke block where there would be a prolongation of PR interval in a minimal fashion until the last beat of the cycle where this interval prolongs abruptly. Now, there's another important feature, and that is due to the shortening of the PR interval after a block B. And as a result of this shortening, the QRS is actually pulled in, and therefore the pause that is there after the block B, the pause is actually less than the sum of the two beats before the block B. And that's again due to the shortened PR after the block B, which tends to pull in the QRS that tends to come relatively earlier. And therefore the pause is less than the sum of the two preceding beats. The fixed ratio block could be localized at the AV node or at the bundle branch system. Now, in a simple fixed ratio block, or let's say a 2:1 fixed ratio block, what's happening is that alternate P wave that's blocked and every other P wave is conducted and the PR interval remains fixed. Now, this kind of block has a narrow QRS complex, and therefore the location wise this block is at the level of the AV node. Now, very frequently a combination of Wenke block and 2:1 fixed block is seen, and both are at the level of AV nodes. And often we see Wenke block periods vary with 2:1 AV nodal block, and the reason being is that it's this combination is seen frequently is because they are manifestations of the same location of dysfunction, that's the AV nodal dysfunction. Now there could be a fixed ratio block with a bundle branch block. Let's say if there is a 2:1 AV block with a bundle branch block. Now in this particular situation, what's happening is an alternate P wave is blocked. Now there is one bundle branch that is permanently blocked, and the failure of conduction may therefore reside in the AV node or in the one functioning bundle branch. Now, if the failure is in the AV node, then with this fixed ratio block, we'll see a narrow QRS. And if the failure is in the one functioning bundle branch, and it's a possibility that we're looking at an intermittent bilateral bundle branch block. And this is a potentially dangerous condition, and it can be a result of transient ischemia. But if you're looking at a fixed ratio, or let's say 2:1 AV block with a bundle branch block with a narrow QRS, then the block is at the level of AV node, and this is a relatively benign situation, and it can be as a result of transient ischemia or by drugs such as calcium blockers, beta blockers, digitalis. The Milbitz 2 block to happen, there has to be a pre-existing bundle branch block, and this kind of block never takes place in the AV node. And this particular situation is a absolute indication for permanent pacing and has grave prognosis, as there is a chance of an asystole that can be catastrophic. Some of the characteristics of this kind of block would be evident if you look at the two beats next to each other. Then the PR interval is the same, and then there has to be a block sinus impulse. Now the next beat would have a PR interval which is similar to the PR intervals of the previous beats, and the pause that's around the block B has to be equal to twice the sinus rate. Now, the complete heart block is where the impulses are not transmitted from the atrium to the ventricle, and it can be localized at the bundle branch system or at the level of AV node. Several important features of complete heart block would be a complete AV dissociation, and there should not be any AV conduction, and obviously no capture beats. A slower rate driving the ventricles, like 45 or less, and of course enough number of atrial impulses to probe all the aspects of diastole. Now here we are looking at a complete AV dissociation wherein there is a separate and independent ventricular and atrial rhythms, and on ECG there has to be changing relationship of P and QRS, and there has to be a regular ventricular rhythm despite this changing PR relationship. And by complete AV dissociation, we are not looking at dissociation of the kinds as in interference dissociation. Now, if we are looking at a situation where there is a complete AV dissociation, not of the interference dissociation kinds, and we are looking at slow ventricular rhythms of around 45 or less, and we are looking at P waves occurring all through the diastole, and if these conditions are accompanied by narrow QRS, then we are probably looking at a complete heart block at the level of the AV node. A complete heart block with wide ventricular complexes can occur when there is a bilateral bundle branch block, or it can also happen in a situation when there is a complete AV nodal block with a bundle branch block. Talking about a bundle branch block. If a supraventricular beat is producing a QRS that is 0.12 second or more in width, then one bundle branch must be blocked. And the defining lead in bundle branch block is V1. Now, over the ventricle that's blocked, there would be a wide R wave, and over the normally activated bundle branch area, there would be a corresponding wide S wave. So if you're looking at V1 and that's having a wide S wave, then it's a left bundle branch block. And if you're looking at V1 and that consists mainly of a wide terminal R wave, then there is presence of right bundle branch block. Now, in situations of incomplete bundle branch block, what's seen is that the QRS is a little narrower than it is in true bundle branch block. In incomplete bundle branch block, the QRS would be around 0.10 or 0.11 second instead of 0.12 seconds. It's like the complete bundle branch block would be a situation where there is no conduction at all. And in an incomplete bundle branch block, the malfunctioning bundle is conducting, but it's conducting slowly. And therefore, the QRS duration would be slightly narrower in an incomplete bundle branch block versus a complete bundle branch block. Another important point is regarding the septal Q waves. It's important to realize that in a blocked left bundle branch, the activation of the septum has to be from right to left, and therefore there cannot be a septal Q wave, and therefore essential to mention the absence of septal Q waves in the diagnosis of left bundle branch block. So in a left bundle branch block, one would notice broad R waves in lead 1, AVL, V5, and V6, and broad S waves in leads 1 and or V2. And absent septal Q waves in leads 1, AVL, V5, and V6. With a QRS duration of 0.12 seconds or more, in a right bundle branch block, there would be broad R waves in V1 and broad S waves in 1, AVL, V5, and V6. And the QRS duration would be 0.12 seconds or more. And in an incomplete bundle branch block, the QRS duration would be around 0.10 or 0.11 seconds, and there would be presence of septal Q waves. In a right bundle branch block, when we look at the V1, then we can notice other waveforms such as small r, capital S, capital R dash. Now, when we talk about the left bundle branch, it's important to realize that it's basically having two different functional elements, and basically they conduct almost roughly in opposite directions, and they are called as fascicles. Now, the fascicles are named as the posterior superior or leftward fascicle and the anterior inferior or rightward fascicle. Conduction wise, the posterior superior fascicle is basically conducting in an upward and to the leftward direction, about minus 60 degrees in a range of minus 40 to minus 90 degrees. And the anterior inferior fascicle conducts downwards and towards the right at an angle of about 100 degrees in a range of plus 80 to plus 120 degrees. And the normal axis would be in the range of plus 30 degrees, given that both the fascicles are conducting normally and they balance out each other. So the normal axis would then lie in the range of plus 30 degrees. Now, if there is a situation where there is failure of one fascicle as a result of disease or any other reason, then due to the unopposed conduction through the functioning fascicle, there will be a deviation of the axis, and that will result in swinging of the axis to the far left or far right. So in a failure of anterior fascicle, there will be an unopposed leftward conduction, and therefore the axis would then lie between minus 40 and minus 90 degrees. And now extreme left axis deviation would generally represent anterior fascicular block, and the conditions that would lead to left axis deviation would generally not lead to axis deviations this far left. And the term hemiblock is used to represent a fascicular block. And left anterior hemiblock is a diagnosis that's based on axis, and in situations where there is a posterior hemiblock, the axis would deviate to extreme right and in the range of plus 80 to plus 120 degrees. But there would be many other conditions that could do so. So therefore, the posterior hemiblock would be a diagnosis of exclusion when all the other causes of extreme right axis have been ruled out. Then one can think of posterior hemiblock as the reason for this kind of extreme right axis deviation. So one can say that it's a diagnosis of exclusion. And also, the posterior fascicular blocks are relatively rare because they have a better blood supply. And if there is a sudden appearance of a fascicular block, especially in situations where there is an infarct, then that could indicate that the ischemic change is involving the septum. In a situation where there is a right bundle branch block along with left axis deviation, then there is a right bundle branch block and the left anterior hemi block is there. So it's a bifascicular block. Similarly, in a situation where there is a right bundle branch block and there is a right axis deviation, then that's a right bundle branch block and a left posterior hemi block. And that's another bifascicular block. Now, in a bifascicular block, there is only one functioning strand that's remaining, and the conduction is hugely dependent on the functioning of this strand. And if there is some interruption or delay through this last functioning strand, then that can produce some kind of AV conduction problem. Whenever there is a prolonged PR interval along with a bifascicular block, then the condition is that of a trifascicular block. So with a bifascicular block, if there is prolonged PR interval, that amounts to a trifascicular block. Myocardial infarction, infiltrative diseases such as the amyloidosis, hemochromatosis, sarcoidosis, and then degenerative diseases of the conduction system can lead to bundle branch blocks. And if you want to find out how to look into if one of the fascicles of the left bundle is blocked in presence of right bundle branch block, then it's important to know the axis when the impulse is traveling down the left bundle. And the axis is then measured from the initial 0.06 second forces of the QRS.